Hi everyone, Tyrone here. Welcome to my MomentMap screencast titled Understanding Anxiety in an Elderly Patient. Because there is a lot of text on the slides in the presentation, I am going to start each slide with 10 or so seconds of silence to give you a chance to at least briefly review the text on the slide before making additional comments. The characters involved in the moment at focus in this map are my preceptor, me, two other PMHNP students, and the patient, Miss M. Yes, this is a really small space for 5 people, but we make it work, largely because our preceptor has really well established relationships with each of us. We students have also grown tight with one another, working together at the site, and our preceptor has excellent therapeutic relationships with the clients, which often extends to us as students. Perhaps because the office space is so small, but also because the psychiatric mental health setting can be sad, stressful, and depressing, humor is one way that we work to establish and maintain a positive, high energy, playful environment for clinicians and patients alike, especially because sadness, stress, and depression are often symptoms our patients cope with in their daily lives. It is important that culture and climate of the clinical setting be a departure from those emotions. The client, Miss M, born in the Midwest and moved to Las Vegas more than 30 years ago. She reports that she did very well mentally and physically for most of her life while working in the healthcare arena. She was diagnosed with ovarian cancer in her 40s and expressed that that's the point at which she feels her overall health began to decline. About 4 to 6 years ago, the client became caretaker for both her biological parents and her brother, all of whom moved across the country to reside in her home when they each became terminally ill without asking permission and while she was still working full time. It is at this time that she notes the onset of her panic attacks and anxiety. As noted in the slide, all 3 family members subsequently died. Her mother died at 74 years of age, her father died at 79 years of age, and finally her brother died at age 57. I might add that they all died on 3 consecutive Christmas days. Shortly after her family member's death, she began experiencing notable issues with her digestion and her throat. She denies family history of mental illness, but admits to a long-term off and on symptomatology associated with anxiety dating back to her cancer diagnosis. My overarching clinical judgment diagnostic impressions of Mrs. M's anxiety is that there are 3 primary potential underlying causes of it. 1, her severe and pressing health situation. 2, her experiences of family health trauma and related loss, and how these experiences may exacerbate her feelings about her own current symptoms. And 3, her limited social support network. Despite feeling elevated anxiety, Ms. M does not appear outwardly anxious. While she admits to significant PTSD and GAD history, she denies any history of drug use or abuse, including alcohol and cigarettes. Ms. M notes significant comorbid health conditions. As already briefly noted, she reports that she was hospitalized for several months from complications due to GI motility dysfunction, hiatal hernia, acute idiopathic irritable bowel. She also notes that she is a stage 3 ovarian cancer survivor. Over the last 4 years, her weight dropped from 110 pounds to her current weight of 74 pounds. Ms. M notes issues swallowing medication, which impacts her medication compliance. She describes muscle weakness in her hands that makes crushing medication unfeasible. Further, following release from the hospital, she reports that her insurance eliminated coverage for her home nursing assistance, so she cannot rely on home nurse for medication assistance either. This image of an elderly white woman like Miss M conveys the woman's confidence in her strength. This was my visualized outcome for the therapeutic conversation with Miss M as I entered into it. That she would come out of the conversation feeling more self assured about her ability to improve her health situation, both psychiatric and medical. With Sue et al.'s work on cultural competency and psychotherapeutics interventions in mind, I specifically chose an image of an older white woman so that, in keeping with my practice commitment to provide culturally responsive care, Miss M can ostensibly see herself in the image. While Miss M does indeed have several obstacles to overcome in order to more fully benefit from treatment, given all that she has already overcome, both medically and psychiatrically, it is clear that she is also exceptionally resilient. According to Edwards and Hall, the concept of resilience in aging was born out of the paradox of old age. The paradox is that in spite of losses and physical declines experienced in later life, adults report feeling content due to resilience. Although resilience is seldom associated with older adults because they experience loss and decline, older adults actually have a higher level of subjective well-being than individuals in any other age group. Resilience thinking in older adults give them the ability to recover from adversity, thrive with a sustained purpose, and grow in a world of turmoil, change, and chronic illness. It is a regenerative capacity that maintains health and function in the face of loss, disability, or disease. While Hubble, Duncan, and Miller, and later also Wampold, asked what evidence exists that lead the clinician to better understand what actually works in therapy, it is clear that the answer includes clinical experience and conviction, both of which my preceptor demonstrated in excess in the following dialogue vignette. I will make one comment per dialogue slide, then remain quiet as I advance the next slide so that you can read the dialogue along with the inserts, thoughts, the clinical reasoning, and descriptive notes to yourself. Please note that I carefully transcribe the ensuing dialogue exchanges from my clinical notes. In this part of the dialogue, the goal was to get the patient to engage in dialogue about how she was feeling about the effectiveness of her medication. In this part of the dialogue, the goal was to gather additional information from the patient's past medication experience to inform the development of her treatment plan. In this part of the dialogue, the goal was to give the patient information to empower her to make an informed decision about her medication. In this part of the dialogue, the goal was to focus on the PMHNP patient relationship and seeking to encourage the patient to trust the information she was being given about her medication options. In this part of the dialogue, the goal was to provide additional information about the benefits of the proposed medication beyond merely the psychiatric benefits as a way of further empowering the patient in decision making regarding her treatment. In this part of the dialogue, the goal of the dialogic exchange is successfully realized. The big four factors around which the heart and soul of change text is organized is based on the clinical work done by Lambert at Brigham Young University. Based on that work, each of the four factors is associated with an estimated percentage that is said to account for the variances in therapeutic outcomes. A client's life circumstances and what they bring to the therapy are described as client extra therapeutic factors, which are said to account for 40% of the variance in client therapy outcomes. As noted previously, though Miss M brings a lot of trauma with her to therapy, she also brings a lot of resiliency. The nature of the client's relationship with therapeutic personnel are described as relationship factors, which are said to account for 30% of the variance in client therapy outcomes. Though Ms. M had strong familial relationships, she is quite socially isolated at the present time, which makes the quality of her relationship with the primary nurse, mental health nurse practitioner, an even more vital importance to her treatment success. Helping Ms. M to resolve her insurance challenges will allow her to reestablish a relationship with a home health aide, and improving her physical and mental health profile will enable Ms. M to partake in more social activities which also have therapeutic benefits. The beliefs that a client has about the efficacy of therapy are described as placebo, hope, and expectancy, and are said to account for 15% of the variance in patient therapeutic outcomes. Ms. M expressed confidence and trust in the PMHNP. Finally, the implementation of the therapist's theoretical orientation, therapeutic methods, strategies, or tactics to move a client to take some action to improve themselves or their situation is described as model technique factors, which are said to account for 15% of the variance in client therapy outcomes. The PMHNP's approach in empowering Mrs. M with information and in her own treatment planning led to Ms. M's receptivity to try a new therapy. Like the initial image chosen, this attractor image, also of an elderly white woman like Miss M, conveys not only that woman's confidence in her strength, but also her sense of calm. I chose this image to portray the vision I had for Miss M's future. It is my hope that this image is attractive to Miss M and inspiring her to pursue positive health practices and to seek out social interactions that make her happy. Again, the selection of an image of an older white woman is intentionally in keeping with culturally responsive, informed care approach. Here are 2 discussion questions to, I hope, get you interested in responding to this MomentMap presentation. I look forward to engaging any questions you have and or hearing and responding to any feedback you want to share. I appreciate your time and attention to reviewing my presentation. Finally, here are the references I consulted, including both the first and second editions of The Heart and Soul of Change text, pioneering the Big 4 major ingredients of therapy.